know, we have a pretty simple vision for this city, and that is that we are working collaboratively to create a safe, inclusive, and innovative city that works for all of us. And of course, these three pieces are all deeply intertwined. We don't believe we can have safety without inclusion and innovation, and you can't have innovation without the safety and diversity of creative problem solving in our city. We also believe that safety, inclusion, and innovation are not things that we can do from city government alone. That achieving this as a city is going to take all of us working together as one Albuquerque, across sectors, across districts, across neighborhoods, to create the kind of future that we know is possible here. So I'm delighted this evening to just briefly introduce a topic that is at the core of those three pieces for us: safety, inclusion, and innovation. Project ECHO, as part of the UNM Health Sciences Center, you'll hear a lot more about soon. But what you need to know is that it is one of the most innovative, creative problem-solving initiatives developed right here in Albuquerque. And we are committed as a city to taking the innovation, which has now been exported all over New Mexico, all over the country, and all over the world, and turning that inward into Albuquerque to solve some of our most pressing challenges. And in doing this, we are standing on the shoulders of giants. This is not new in our administration in the city. We have leaders here tonight like Dan Duhigg, who first brought the ECHO model, which, as you'll see, was originally designed for health and public health applications, to the realm of public safety. Dan and his colleagues, Detective Matt Tinney and Dr. Niels Rosenbaum and Jennifer Earhart, were pioneers in taking the ECHO model and translating it into how we better train police officers in APD and across law enforcement in the state and the country to handle complex mental health challenges in the field. Today in the city, we're building off of the success that they have had of that over the last couple of years to develop and pilot a project for downtown safety in Albuquerque that uses the ECHO model to create a community of practice and learning among public safety and security professionals in the downtown region, and also engages a much wider group of stakeholders to collaboratively address some of the challenges, including mental health, addiction, and broader public safety challenges affecting our entire city. So we are excited to be part of this collaboration and be working very closely with Project ECHO to build on what previous administrations have already started in this city. And excited for those of you here to learn more about how this model is applied locally, nationally, and internationally as well. So with that, I'll turn it over to the rest of the panelists. Thank you again for being here.
It's my pleasure to introduce the panel this evening. Dr. Sanjeev Arora is the director and founder of Project ECHO. He is a distinguished professor of medicine with tenure in the Department of Internal Medicine, University of New Mexico Health Sciences Center. Project ECHO, Extension for Community Healthcare Outcomes, dramatically improves both capacity and access to specialty care for rural and underserved populations by linking expert interdisciplinary specialist teams with primary care physicians through tele-ECHO clinics, in which the experts mentor primary care clinicians to help them manage their patient cases and share their expertise via mentoring, guidance, feedback, and didactic education. This helps rural clinicians develop knowledge and self-efficacy so they can adopt research findings and deliver best practice care for complex and chronic health conditions. Glad to have you, Dr. Aurora. Dr. Martin Kistin is a gastroenterologist and a professor of medicine at the University of New Mexico School of Medicine in Albuquerque, New Mexico. He served as the Gastroenterology and Hepatology Fellowship Program Director for 10 years. Prior to that, he had a gastroenterology and hepatology practice caring for patients throughout New Mexico. He currently works with Project ECHO in Albuquerque and is part of the Project ECHO replication team, helping to spread ECHO throughout the world. He works with the United States Defense Health Agency to support and spread the ECHO model within the U.S. Department of Defense, and is working to apply the ECHO model in the areas of education and quality improvement. Dr. Kistin did his medical training at Tufts University School of Medicine in Boston, and his residency and GI and hepatology fellowship at the Tufts New England Medical Center in Boston. Dr. Daniel Duhigg serves as Behavioral Health Mental Director for Presbyterian Healthcare Services in Albuquerque, New Mexico. Prior to his current role, he was the Addiction Services Medical Director for Presbyterian Healthcare Services and specializes in addiction psychiatry for the Behavioral Health Department, where he continues to see patients. Dr. Duhigg is a member of the Addiction Treatment Advisory Board of Bernalillo County, New Mexico, and a member of the Board of Directors for the New Mexico Monitored Treatment Program. Dr. Duhigg holds a doctorate in osteopathic medicine from Kansas City University of Medicine and Biosciences, and a master's in business administration in healthcare leadership from Rockhurst University. Welcome, Dr. Duhigg.
First of all, I want to thank the Albuquerque Academy for inviting us here. This is the very first time. I've always been sitting on these seats. It was the first time I'm on this stage. And, but I want to assure you that as a team, we are uniquely qualified to be on this stage. And the primary reason for that is together we have paid 42 years of tuition to this school. I think we deserve this right to stand here. I think the second point I want to add is that I'm a little nervous. I've never spoken before a First Lady before. Now, she may not have been the best guitar player at Albuquerque Academy, but I can assure you she was the best debater. And I've been told you don't want to follow Elizabeth Keller with a speech. So anyway, now to more serious things. As you heard, I'm a gastroenterologist. And at ECHO, our mission is to democratize knowledge, to get best practice to underserved people all over the world. We have a goal to help 1 billion people by December 31st, 2025. So I'm going to take you back to 2002. I'm a gastroenterologist and liver disease specialist, and I was treating a disease, hepatitis C, in the University of New Mexico. I have a hepatitis C clinic. It's every Monday afternoon. And there used to be an 8-month wait to see me. This is in 2002. I was literally running the only hepatitis C clinic in the state of New Mexico. This is a disease that affects 70 million people worldwide. And without treatment, 20 million are going to die. And they are dying every day all over the world. But in New Mexico, in 2002, there were 28,000 patients who'd already been diagnosed. These patients were trying to come to see me in my clinic, and there was an 8-month wait, and there were people who were driving 200, 250 miles each way, making 12 to 18 trips while they were taking these weekly injections of chemotherapy, which I was giving them to cure their infection. And the infection was curable. But in 2002, the problem there was that less than 1,500 of these 28,000 had received treatment. And the others were all trying to get in somehow with someone. And I saw this 43-year-old woman. She had come to my office at the university, and she had hepatitis C, and she'd been having some pain now in her liver area. And so I asked her, when did you find out she had hepatitis C? She was a single mother. She had 2 of her children with her, a 14-year-old boy, a 9-year-old girl. They had come for the clinic visit with her. They had driven 5 hours to get to me. And she said that, look, I've known about this for 8 years, and her husband had died in a car accident 5 years earlier. And she was very poor. She didn't have a lot of money. And she lived in one of the towns. I won't give you the name because of patient confidentiality issues. And so she was having this pain, and I did some tests, and what we found was that she had a cancer in the liver, which was a little bit smaller than the size of a baseball. Literally, it was incurable. So I mentioned that 20 million people will die. The way people die of hepatitis C is they get liver failure, cirrhosis, or they get liver cancer. So she was, at this point, really begging for help because she was concerned that if she was going to die, her 2 children would be orphans. And this was really, really a problematic case because there's not much I could do. The cancer was too big to get a liver transplant. It was too big to take out 3/4 of her liver or anything like that. And so despite the fact that she really wanted to get better, and we couldn't do anything, and she passed away, leaving these 2 children. And this was a real problem because this was not the only person that was happening to. It was happening to hundreds of people all the time in New Mexico. In my own practice, it has happened to more than 100 people. So I was trying to ask myself, what's going on? And I had asked this patient, why did you not come earlier? You've known this, you've had this for 8 years. And she said, look, I didn't have the money and to hire babysitters. I would have to take kids out of school. I couldn't come here 12 times, 5 hours each way. And there was no one in my town who had the knowledge to treat hepatitis C. It was a very specialized disease. And this was a time that I'd been treating hepatitis C in New Mexico for already 9 years, and I had never had a patient for which I couldn't find the medicine. The medicine was available, the blood tests were available, everything was available, but the knowledge to treat this patient close to their home was not available, and that's why she died. And that's why tens of millions of people die every year all over the world, not because the money is not available. The medicine could be in the next room, but if you don't have the knowledge, you can't make the diagnosis, you can't have the treatment. And that's the problem we're trying to address. That's how ECHO was started. The key strategy is to move knowledge instead of moving people, because moving people is difficult. So what did we do? We said we would change the game and create a new model where we could bring access to care for hepatitis C treatment with chemotherapy anywhere in New Mexico, so anybody could be treated. And then we'd have a model for complex disease in rural locations in developing countries. And the model is based on 4 ideas. One is to use technology to leverage scarce resources, and in this case, the resources were a psychiatrist, a pharmacist, and a liver specialist. It was hard enough to get these guys in a university, almost impossible in a rural area. The second thing we did was we said we would create 21 centers of excellence for treating hepatitis C all over New Mexico. 5 were in the prison system. What I didn't tell you was 43% of the prisoners also had hepatitis C. So what happened is we created these centers, and you had to have a nurse practitioner or a family doctor to be called a center of excellence, and we gave them our protocol. We said, here, this is how you should treat, and not a single one was willing to treat hepatitis C because of the protocol. So I asked myself, how did I become a specialist in gastroenterology and liver disease? I wasn't born that way. So when I did my fellowship in Boston, from the day 1, they put me in a patient room. I would see a patient come out, present to my professor, see a patient, professor, see a patient, present to professor. And after 2 years, they started calling me a gastroenterologist. I said, aha, I'm going to use this model to create new hepatitis C-ologists in New Mexico. That was the model. We call it case-based learning, and that we would use the web to track outcomes. So this is what we started in 2003. Every Wednesday afternoon from 3 to 5 p.m., all 21 of these primary care clinicians from all over New Mexico would join in an interactive video network. First, Deb Newman would present a patient of hepatitis C to us. We needed about 20 pieces of information. She'd give it all in about 5 minutes, always in the same sequence. We would all discuss it. Everyone would ask questions, give advice. Then we'd go to Las Cruces Department of Health, Las Vegas, over the course of 2 hours, we'd co-manage 10 patients and give them a 15-minute lecture. And every echo was exactly the same. About 10 cases. We never mentioned the name or where they live, etc. Just cases. So we started doing research. As this was going on, we found that their professional satisfaction was going up, their isolation was going down. Echo was actually producing something we hadn't anticipated. It was producing joy of work for these rural clinicians. And their competence went up dramatically. Here the scale is 1, I have no skill, 7, I'm an expert who can teach others, goes from 2.8 to 5.5 in 12 months of participation in echo. But we asked them, has it diminished your professional isolation? 4.3 out of 5. Enhanced my professional satisfaction? 4.8. We asked doctors, has it expanded access to HCV treatment in your community? 4.9 out of 5. The expansion of access was so good that over 18 months, the wait in my clinic fell to 2 weeks. From 8 months, anybody could get access to hepatitis C treatment, because I said the medicines were available, the tests were available, within 2 weeks. So we've treated thousands of patients. Last year alone, we treated 2,200 patients in New Mexico, just to give you an idea. But the other thing that was perplexing was this next question. Access in general to specialty expertise is a major area of need for you and your clinic. 4.9 out of 5. In the United States, we have twice the number of specialists as Western Europe, 50 times out of Africa, and yet our rural doctors can't access specialists. That's why tens of millions of people are dying every year, because the right knowledge doesn't exist at the right place at the right time, and then it's impossible to get the right care. Of course, we did an outcome study. This was a head-to-head study published in our leading medical journal of the world, New England Journal of Medicine, where we showed that these rural doctors could produce the same level of care and have exactly the same cure rates as we were getting at the university. This paper literally changed the world for us, because all of a sudden, everyone in the world got interested in echo and how to apply it for their diseases and their things and so on and so forth. And we described criteria. We said, hey, this is not a hepatitis C game. It can be used in veterinary medicine, but it also can be used for common diseases, complex diseases, where new treatments are coming, where we have effective treatments and lots of people are suffering. You can use this model. And the goal of echo is what we call force multiplication. What we are saying here is, if you can make a nurse practitioner provide the same level of care as a super specialist, then you get 10 times. Why do you need 10 times? Because there are 6 billion people in the world for whom the right knowledge doesn't exist at the right place at the right time, so no right care. But if you do 10 times, you can address it. If you double the number of specialists in the world, then 5 billion don't have access. This is a huge problem, and that's why you need a different kind of solution. So what do I be doing? And these are all the echo projects we run. You can see how many there are. Autism, behavioral health, osteoporosis, heart disease, HIV, high-risk pregnancy, mental health, addictions, sexually everything. I mean, we have more than 70 different disease areas, 33 countries. So the first slide said, want to help 1 billion people. How would that happen? We had to teach other people to do it. We taught the VA system to do echo many years ago. This is a paper they published 4 months ago, where they showed that if their doctors, primary care doctors, participated in echo, the likelihood their patients would die from liver disease was 46% lower than if their doctors did not participate in echo, because these primary care doctors didn't have access to best practice. So of course, what we started doing is teaching other universities to do echo, because we couldn't do it all. Even though we had created this in Albuquerque, we couldn't do it for the whole world. So we started training other universities, and in partnership with them, we now have 129 actual peer-reviewed publications showing that echo is effective, that it leads to physician learning, improves quality of care, improves access to care, lowers cost, and many, many other things. And this is, of course, Albuquerque. This is our hepatitis C program in New Mexico. These are the 400 points of contact we have in New Mexico for 39 disease areas. This is the VA ECHO program. 11 university hubs connected to 600 clinics for 39 disease areas. US Department of Defense ECHO, which Dr. Kistin supports, where they have programs in Belgium, Germany, Italy, Japan, South Korea, etc. These are the now 141 universities in the United States that have replicated ECHO, all the way from Harvard and Johns Hopkins and Yale, pretty much, and to UCSF, University of Chicago, MD Anderson. Most of the major universities in the United States have already replicated ECHO. We are in 33 countries now with a total of 241 launched hubs connected to. I learned this morning that in 2018 alone, more than 20,000 clinicians have participated in ECHO. And you can imagine it's been going on for 15 years all over the world. And so we are in Australia, Myanmar, Vietnam, India, many African countries, many Latin American countries. And what we are looking for you is, we want you to partner with us. This is managing HIV in Africa, where in Namibia there are 200,000 HIV patients, and less than half are on treatment, and we are training all the other hospitals to train HIV. The Vietnam multi-drug resistant TB, India multi-drug resistant TB ECHO. So the ECHO Act was passed in the United States Senate 2016, which basically, it passed 97-0 in the US Senate, and President Obama signed it into law in 2016. And the importance of this is that the US government has decided that ECHO is a good way to, that's the importance. It's a good way to democratize knowledge. And you'll hear, it's not about health, it's not about healthcare. This is far bigger than that, because this lack of specialized knowledge is so important. So what really makes ECHO work? Team-based care. Task shifting is the idea of every human being working at the highest level of his human potential. If you have many experts helping you, like we have in ECHO, interprofessional consultation, if you have guided practice, the idea of guided practice is that how many of you have taught your son or daughter to drive a car? If I told you you could give her lectures on how to drive a car, would you give her the keys to the car? So this is the problem in medicine and many other areas. We need guided practice. We need someone to help us practice and get better before we get the keys to the car. And a mentor-mentee relationship. If you have all three, human performance improves. ECHO is a social network. It produces joy of work. About 40 of our publications show that. And all teach, all learn is the idea that it's not the specialist teaching primary care. We learn from primary care because they bring the social, cultural, economic context in which patients live, which modify what we do. So this is a way we all collaboratively learn, and that's why I'm so excited about that, the First Lady's program in safety. Because if we want to improve safety in Albuquerque, we have to have all the stakeholders come in, present their solutions, come up with new ideas, have them communicate on a regular basis, try those ideas, and make them all stakeholders work synergistically rather than competitively to solve this big problem. And this is exactly what we do in healthcare and what we are going to do in education. And it's a movement, and we need your partnership to change the world. We want to literally change the world, and we want you to join us as partners. Thank you for your attention.
Good evening. I'd like to thank Lori Peterkin and her team from UNM for setting this up and giving us the opportunity to be here this evening. I'd like to thank the Albuquerque Academy for hosting, and certainly like to thank all of you for being here with us this evening to let us talk about our absolute favorite thing in the world, which is Project ECHO. You've heard Dr. Arora talk about the beginnings and where Project ECHO is today and the kinds of things that we're doing in the field of healthcare. it's important to emphasize that our mission is to serve the underserved, and that generally means for us getting best practices to that last mile where they frequently don't get to be applied. The model we use to do that involves a number of things. It involves mentoring, it involves networking, and it involves creating learning communities of respect and collaboration that has resonated with people all over the world who want to participate in that. And it's particularly important in this day and age. We have a lot of problems in our city, in the state, and around the country. And sometimes it's tempting to say, God, I'm overwhelmed by all this. I'm just going to drop out. I'm not going to participate. But I can tell you from what we've seen and the way this has been received by people all over the state, all over the country, and around the world, that it is particularly important in this day and age for people to resist that temptation and to get out and to continue what you do, support each other, support your friends and neighbors, and if you're doing work that has synergies with ours and can collaborate with us, that's great. And if not, if you can support each other, there are plenty of folks at the city and around the state who have fantastic projects to help solve some of these serious problems. It is a little ironic. I am a gastroenterologist and a physician, and am in charge at ECHO of our non-medical partnerships. A couple years ago, two amazing groups came to us, one from the Ambient School in India and one from the University of Wyoming in Laramie. And they said, they had heard at different places about the ECHO model. And they said, you know, as much as this applies to medical practitioners, this could apply even more to teachers around the country and around the world. And the folks at Wyoming were specialists in something called assistive technology. What they do is they research and mentor people in using apps and computer technology and devices for special needs children to help them get through their day, to help them get through school. And so what they were doing, which is typical of a lot of places, is they would accumulate these best practices and this evidence. They would get in their car and they would drive out to each of the 46 school districts in Wyoming, and they would share their information and their best practices with special ed teachers in each of these school districts. When they heard about the ECHO model, they said, we could meet with all 46 of these school districts every week without ever leaving the building. And so they set up an ECHO network for assistive technology where the special ed teacher in all of these 46 school districts present cases to them of kids that they have, what they've tried, what has worked, what hasn't worked, and they share with them using the exact same model, case presentations and a short didactic to support these teachers. And an amazing thing happened in a very short period of time. Regular classroom teachers heard about it and came to them and said, well, that's great, but we need this too. And they set up a second network for regular classroom teachers. And about that time, the state of Wyoming heard about it. And they said, you know, you're doing the work that we need to do anyway. Why don't we pay you for it and have you do more of it? And so there's now a line item in the budget in the state of Wyoming for ECHO for education that's several $1 million a year. And within a short period of time, these folks had increased to 9 different ECHO networks. That's 2 hours a week for each of those networks with a different group of 46 spokes, different target audience around the state of Wyoming. So after the teachers had gotten 4 or 5 different networks, the principals came to them and said, hey, we need this too. And then the school superintendents. And so all of these are linked by ECHO networks in the state of Wyoming at this time. The Ambient School in India said, we can really use this. What we need is one standard of teaching throughout the country. And so they used the model to train math and English teachers, initially in the private schools, and then the government again heard about it and got involved and said, man, we can use this as well. We have similar standards. We're going to roll this out eventually to the entire country to be able to do this with this model. In New Mexico, we've just finished our first pilot project using the ECHO model in education. Public Education Department from the state came to us about a year ago, and they said, we have some evidence, well, we all have the evidence, that the graduation rates in high schools in New Mexico are the worst in the country, south of 70%. They said, but we have some data that kids who participate in career enrichment tracks or technical education tracks graduate at a rate 10 to 15 points higher, regardless of what the graduation rate is for their school. And they came to us and they said, we want to spread this around the entire state. And so we talked to them and we decided to try an ECHO project to see if we could mentor educators around the state in schools around New Mexico and help them apply these principles to their schools, support the teachers there, realizing that it would be a little too short term to know if we could really impact graduation rates, but just to see what would happen if we did it. So the goal was to share best practices and support teachers around the state in these career technical education principles. At the hub were education specialists who were specialists in this CTE track, but we also recruited Golden Apple teachers from around the state and board certified teachers from New Mexico. Spokes were 46 educators from 24 schools in 12 counties around the state. And experts were zoomed in. That's the technology platform we use. It's like Skype or FaceTime. But the experts were zoomed in from around the state, from around the country. They don't have to be in the room to provide expertise to this network. And interestingly enough, the experts were the specialists, the educators we had at the hub, but also the spokes. Many of the spoke teachers who were on this network had been teaching for 15, 20 years and were experts in their own right, and so could participate in this all teach, all learn model. And they would present students or groups of students as the cases, but quickly it evolved so that the cases were process issues that the educators were concerned about in their schools that they wanted to talk about and get input from the hub, but also from the other spokes about how to solve some of these problems. So map of New Mexico, the darker the area, the more spoke participants were involved. You can see it did involve almost the entire state in different areas. And this is what the network looks like. It's that Hollywood Squares model, but on this one, you can see this arrow over to the right. That means there's a whole nother page of squares, just like this one, for all the people who are participating every week in this education network. And so we did some focus groups following this to see how this had impacted the teachers. And not surprising to many people, although as physicians we weren't so sure, the impact on teachers was exponentially greater than the impact on physicians. And these were some of the quotes from our teachers at the end of the session. I found the sessions empowering. I was amazed by the common difficulties we share with other school sites. I'm grateful to be part of such an innovative movement for our state and for education in the future. I've taught in 4 different school districts in 19 years. This is the most organized and most personalized development I have ever, their caps not ours, participated in. The information, resources, and recommendations presented and shared are relevant to our students and our professional and educational needs. We now have 3 other ECHO projects in education in New Mexico. We're doing a second year of the Career Technical Assistance ECHO project. We are now doing a support ECHO network for what is called Teacher Pipeline. This is to support teachers who teach high school students who are interested in going into the field of education. The third one is something called Early Warning Systems. This is a system of metrics developed at Johns Hopkins in Baltimore and the College of Education and being tried throughout New Mexico now. We have metrics to try to identify kids in middle school and high school who are at high risk of dropping out, and then have interventions that can be applied to try to retain them in school. And this is being rolled out to teachers around the state of New Mexico. We are talking to folks in the legislature now about possibly setting up an ECHO network to support early teachers in the first 5 years of their teaching career. The dropout is 50%. Seems we ought to be able to lower that significantly. And probably the most exciting for us is we are collaborating with the city for an early childhood education. The city employs 100 teachers in 22 different sites around the city, and this has recently become our passion. It is our feeling that you can probably do exponentially more good in people's lives by addressing early childhood education than you can with all of our medical echoes. We know every study that has been done linking education and health has shown a positive linear result. That is, the more education you have, the better your health, and the more likely you are to live longer. Conversely, the less education you have, the more likely you are to have disabilities, chronic illness, and you may live 5 to 10 years less. The amazing thing about that, we are discovering as we review all of these studies, is that you can impact that in children while you are dealing with the root causes like poverty and terrible homes and ACEs. What that means is you can impact this without getting to the root cause, although of course we still want to do that. We know that poor kids who end up in kindergarten at age 5 have a 3 million word deficit. That means not individual words, but 3 million words fewer that have been spoken to them in the 0 to 4 age. The amazing thing is, with good early childhood programs, you can overcome almost that entire deficit. So our vision now in the field of education is to collaborate with educators to provide a single world-class, evidence-based, state-of-the-art early childhood program, and to be able to do it with materials that can then be scaled to our partners around the world. Thank you.
Good evening. The First Lady invoked standing on the shoulders of giants. Not sure how I feel. Amazing. Amazing folks. I want to tell you about a problem that existed in our city and that continues to exist in many communities, and the solution that we have been working on. And I think one of the best ways to do that is to introduce you to Christopher Torres. Christopher was a 27-year-old male in 2011 who was living with schizophrenia. And sometimes folks with schizophrenia develop ideas that aren't exactly true or real. We call these delusions. Christopher developed the belief that he had the authority to disarm people who were not part of law enforcement. He felt that that they were a risk and a threat to safety. In fact, he even began to patrol the city in his car, and he would try to pull people over who he believed had firearms. People wouldn't pull over, but at red lights where they were stopped, he would get out of his car, and he was upset at this and agitated and would act agitated in the street. He, of course, was at risk himself, and people in general felt threatened. They didn't know what was going on. He even tried to disarm somebody in a restaurant who was either carrying a firearm or he thought had a firearm. So things were escalating. And one of the ways to try and intervene was to serve him a warrant based on road rage, based on how he was acting out in public. And so 2 plainclothes police officers went to his home to serve him this warrant. And they were plainclothes. They weren't wearing uniforms. So Christopher saw 2 individuals with weapons and doing what I believe he felt was his civic duty. He attempted to disarm them. Now, as law enforcement, somebody who reaches for and even touches or takes your weapon, this is a life and death situation. And that's training for law enforcement. And so, in his own backyard, this 27-year-old New Mexican living with schizophrenia unfortunately had lethal force used against him. It's a tragedy. What makes it even a little bit more painful is that the Albuquerque Police Department at this time, and still, has a unit dedicated to interacting with people living with mental illness. We call this the Crisis Intervention Unit. It's an amazing unit. And they knew of Christopher. He was, in fact, on their contact list. The idea being, if anybody interacts with him, call us. We're the experts. We know how to interact with people with mental illness. And unfortunately, there was a lack of communication infrastructure in APD at the time. And this resulted in these 2 plainclothed officers not knowing that he was on the contact list and not knowing to call in officers with mental health expertise. A tragedy. So here the problem was we had a person living with mental illness who was engaging in unsafe behaviors, which most people with mental illness do not do. But this was happening, it was escalating. And the keepers of the peace, they needed expert knowledge. And they needed it fast, they needed it in time, with tragic and unfortunate outcomes. So what is the solution? The solution to this situation had many parts. And part of it included training for law enforcement and also forming partnerships with us at Project ECHO. And also some audacity, right? The courage to try something big. So what are the parts of the solution? Education and networking are really what it comes down to. The education part is what we call CIT, or Crisis Intervention Team Policing. It's not something that we invented. This is really a community policing approach with an understanding and a skill set for interacting with people with mental illness. It first and foremost includes education on how to identify mental illnesses. We literally train law enforcement on this book, the DSM, that defines all of our mental illnesses. This is what schizophrenia looks like. These are the symptoms. This is what bipolar disorder looks like. These are the symptoms. This is depression, anxiety. These are substance use disorders. We also teach verbal de-escalation. Let's calm the situation down with words and with body language so that we do not need to use force. We do not need to draw weapons. It also includes, my favorite part, jail diversion. If we interact with somebody, I say we, I'm not law enforcement, but if law enforcement interacts with somebody who is in a mental health crisis, who might be breaking laws, jail is probably one of the worst places for them. They have an illness that they're suffering from, so instead, let's bring them to a hospital, which is exactly what is taught. It's incredible. And then the importance of developing a relationship. This is what community policing means. It means that when law enforcement is called out to interact with somebody because they get a call of a disturbance and they're clearly in a mental health crisis, after that call is over, the CIU might go back and just check in. How are things going? Are you in treatment? You have a doctor? Are you taking your medicines? And they actually develop a relationship so that people can build trust and not fear of law enforcement. This is real peacekeeping. It's also, of course, what we've done is developed a relationship. The limitation of traditional CIT training is that while you get your 40-hour class, which is the standard, there's not a lot of upkeep. So you do your 40 hours and then you're kind of sent out into the world. I don't know if any of you have ever tried to learn something and you watch a YouTube video, and then like 3 months later, do you know what you're doing? Right? Skills take upkeep, which fits perfectly with case-based learning. So if an officer traditionally was out in the field and interacted with somebody living with mental illness, maybe they remember some of these skills, maybe they don't. But if they had a question, it wasn't clear what to do. It wasn't clear who to call. In Christopher Torres' situation, that was painfully clear. So, we came up with an idea. This was myself. I'm an addiction psychiatrist and an echo zealot. And Detective Matt Tinney with the Crisis Intervention Unit, and Dr. Nils Rosenbaum, who was a law enforcement psychiatrist with APD. We thought, well, what about if we pair a crisis intervention team expert with a mental health expert? Then, somebody in the field who has questions about what to do, who has experience. I tried this, it didn't work. What can I do? They can connect to not only these experts, but a whole network of people in law enforcement. And we can share best practices. We can talk about what was done. We can do brief lectures and continue the education about identifying mental illness and de-escalation techniques, but use real-world cases where somebody says, you know, I was interacting with somebody and they were walking in and out of traffic trying to stop cars because of the beliefs that they had about the importance of doing so. And they were at risk. And when we tried to kind of do our command and control and say, get out of the street, get out of the street, it didn't work. Maybe we had to finally tase them or stop traffic. What was going on? So we would review cases like this and say, next time, try this instead. And then they come back and they said, we tried it and it was awesome. No use of force. And then we got them help. So it worked. This is the CIT ECHO model. Because so many folks in law enforcement are interacting with a large number of people living with mental illness. So one case can have a huge effect. This is what it looked like when we launched. So a little bit different, you notice. These are police officers. That guy in the lower, your left-hand corner, his phone's on his dashboard of his patrol car. It's so important to him to connect with other people in law enforcement who understand mental illness that he connects hands-free in his car. In the other corner, that's the police academy, where now we train everybody who goes through the police academy on how to connect to the CIT ECHO. At this point, now we have so many squares in our Hollywood squares that it fills up the screen. And we realized very quickly that we needed to open it up to all first responders, and so that's what we did. So we have our hub, we have a psychiatrist, we have crisis intervention unit detectives, we have crisis specialists who are like social workers, and a project coordinator. And we really opened it up to the police department, to paramedics, to corrections, to fire. When people call 911, sometimes the fire department is the first one on the scene. And if it's a mental health crisis, We want them to also understand what is the safest way to proceed while they're waiting for others to arrive. Probation and parole, because they continue to have relationships with some of these individuals for a long time. Over the first 18 months, we connected to 34 agencies initially. Over 200 participants, 200 individual people who connected, lots of continuing education. And in that time covered 51 of these calls, 51 entire cases. Sometimes it's a one-time thing where somebody says, here's what happened, I interacted with this person. Sometimes people keep connecting week after week. They say, you know what, we got a tip that somebody wants to assassinate a politician. They're under the belief that they are saving the world by doing so, and that this person is sending them messages. What do we do? And so we would staff that case longitudinally, help them week after week. At this point, New Mexico is covered. In fact, we have 17 law enforcement agencies across the state and 12 other law enforcement agencies across the country, and one in the province of Ontario. This has really caught on. This is something that's needed everywhere, and a lot of enthusiasm from folks who connect. But here's the best part, and we can't take credit for all of this, but this is a graphic showing that nowadays, or very recently, between August of 2016 to January of 2017, each one of those figures represents 1,000 calls for service. It's 1,000 calls to law enforcement in New Mexico. This last part of a stick figure here, that foot is at this point the number of use of force used. APD has almost no use of force now. And in fact, if you break down the foot, it might be hard to see from where you are, but this little sliver of blue, that's serious use of force. It is almost nothing from a police department that was scrutinized so much by the Department of Justice that they really had to change things. And they changed a lot. ECHO was just part of it, but it's a really important part, and it's a really fun part. So the question, I think for all of us, is what now? What now for people living with mental illness in New Mexico? Well, they're far more likely not only to have a safer, but even a therapeutic interaction with law enforcement, where law enforcement can help link them to mental health treatment, can actually develop a relationship and help them get services. But what about what now for the rest of us? And why even share what we're doing with you? All of us live in communities. Big, small, social, professional, spiritual. My question, and it's a challenging question to you, is to think about what changes are needed in your community or your communities. Who do you need to partner with? For this project, me as a psychiatrist at the university at the time, I had to partner with law enforcement, right? We've been partnering with educators, partnering with rural primary care providers. None of us could have done this alone. It takes these networks, it takes partnering. And the thing is, you don't have to create a worldwide, a nationwide, a statewide solution. Even thinking about that can sometimes be overwhelming, and then we don't want to act. I say focus locally. Identify a problem, figure out who you should partner with, and be audacious. because it's a lot of fun. Even if it doesn't work out, you tried, and you can have an amazing effect, even in your neighborhood, very locally. So change the world, change the city, change your profession, change your neighborhood, change your block, and do it fast. Because there's really no time to wait. I want to thank everybody for coming out tonight. I want to thank the Albuquerque Academy and the City of Albuquerque for filming. We're going to stick around a little bit and do some questions and answers, some Q&A if you have any questions. We've got our whole panel. We'll move our seats up, and we have some microphones up here up front, and we would be delighted to answer any questions that folks have. Thank you.
I think it's wonderful that you've been working with the police department with mental health. My question is, what about brain injury? Brain injury is not a mental health issue. It's a brain injury issue, and those people have a very difficult time because they often look absolutely normal, but have a very difficult time in dealing with all kinds of problems. Is anything going on with ECHO for brain injury?
Of course.
Yes, there is in fact. So we have a TBI, or traumatic brain injury echo, run out of the Echo Institute here in Albuquerque by Dr. Mark Pedrati, which has been received all over the state, but also all over the country, has participants around the country. And we just recently launched the first brain injury echo in the Department of Defense, started by the Navy. The main hub is Navy hub in San Diego, and this is being done in conjunction with the VA there. So this is going to be a huge project, and we are currently speaking with other stakeholders who have a huge interest in this, including the Center for Disease Control in Atlanta.
I can actually talk from here.
Okay.
Do you ever bring the different communities together, physically together? And do you think it's purposeful to do that?
You know, a lot of echoes in the last 15 years, you know, many have started, and what we found is that the video conferencing platforms are amazing, but it's nice at least once to bring people together, to shake their hands and get to meet them. After that, that relationship can be maintained for a very long time on our very high definition video with 4K screens. But we've at least found that's a very helpful thing in the beginning to develop the kind of, because as you heard from Dan Duhigg, it's about partnerships. You know, ECHO is not a magical thing. It's just an idea of sharing. What we are saying is, you cannot do it and I cannot do it, but together we could do it, right? Because we have complementary skill sets. So bringing those together and just sort of, but also the primary reason why ECHO works is not knowledge transfer. It builds relationships, and with empathy and kindness and trust and other human you know, traits and needs which it meets, and therefore that first time meeting in person is very helpful.
So that's something called meta-echo, and it happens every other year on average?
Yeah, it's happening in March 13th to 16th, 2019, and you're all welcome to come and join this conference. There'll be people from everywhere in the world there who are doing ECHO to try and change the world.
And that happens here in Albuquerque. It's amazing.
The convention center.
Returning to TBI for a minute, I understand there are a significant number of TBI cases at BCDC. What is being done to address that through the psychiatric unit at BCDC and to deinstitutionalize them and return them to the community?
I'd love to have a conversation with you outside of this about kind of what is done with mental health there. There have been a number of jail and prison-based ECHO programs which have been quite amazing. Do you want to?
Sure. You know, I think you're making very, very good points. What happens is when you don't have the right knowledge in the right place at the right time, there is incalculable human suffering. And TBI is definitely one of those things. But also just being in the prison, it's very difficult to get good care there. But it's not like we lock them up for life most of the time. And they come out. They're part of our community. And so if you don't take care of them there, they come out. And then we spend 10 times, as like in hepatitis C, you don't treat a prisoner in the prison, they come out and we do liver transplant. They get Medicaid on the day they come out. And then we pay for a liver transplant with $250,000 instead of treating them in the prison. So I think that as a community, if we work together, getting all these pieces together, then we can do better. And BCDC is no exception. They can do better too.
Yeah, one thing that we found, because I appreciate the questions about brain injury, that of course there are many psychiatric sequelae of it. And so folks who are familiar with the community with traumatic brain injury are likely familiar with the fact that we also have a disproportionate representation of people with TBI or brain injury in the judicial system. So we talk a lot about it on the CIT Echo, and part of our goal is to help and prevent folks from ending up in jail and prison, right? Again, by fostering these long-term relationships and helping them to get into treatment. But another thing that the CIU does, which is really just an amazing unit at APD, is they will go and visit folks in jail and prison. If they don't already have a relationship with them, they'll start the relationship there. And again, when they come out, they follow up with them, try to help to be therapeutic, which is really, I think, the best possible outcome with law enforcement. Pretty amazing.
And I'll say one other thing about that. These things frequently are all related. We have a division within the ECHO Institute that deals with peer educators within the prisons. These are prisoners who we network with and collaborate with to do health training to other prisoners in the prison system. But I was just meeting today with the person who directs that program in our office, and he said, don't you think, like early childhood, that providing education to this population while they're incarcerated would decrease the rate of recidivism and improve the outcomes from people who are incarcerated once they're released. So this is another aspect of it that we're starting to look at.
Dr. One of the charts that you showed pinpointed where throughout the world where all of these ECHO programs are being set up. And I noticed the United Kingdom was full of dots, and Western Europe had none. What's the explanation for that?
Yeah, you know, what happens is, the question is, UK, United Kingdom had huge number of dots, and Western Europe didn't. You know, partly it's just a resource constraint we have. You know, what happens is we don't go around to people telling them do echo, right? Because we have limited resources. And only people who come themselves, they have to trek all the way to Albuquerque. United Kingdom has sent many teams, and they are on track to start 30 hubs for their own country. They see the value in many areas, because they have a huge problem in United Kingdom that they have what is rated by independent body as the best healthcare system in the world right now. But specialty access is a challenge. People have to wait long waits to see a specialist, and so they find enormous value in it. But you know, if the Western Europeans came to us, we would train them too. We don't, but it's just we don't have the resources to go around the world and just put it in every country. They have to come up to Albuquerque. In fact, thousands of people come every year to Albuquerque. And just as a result, as an economic development tool, ECHO has brought in $100 million of grants to Albuquerque, which is, and our conference will get 1,000 people from all over the world to the convention center to enjoy our wonderful weather, and they're coming in March, which is beautiful. So
I have two questions, if I may.
Sure.
The first is, I work with schools and school districts all over the state. how can I assist when I'm meeting with all these schools, wherever I'm at? And the second part of that question is, are you hiring?
So, I think we are, actually we are hiring most of the time. ECHO is growing quickly, but I want to give him the specific answer. But I want to give a general answer. He'll answer the actual education question. ECHO is about partnerships, as you heard. Every one of you can be involved in ECHO in some way. You can participate in an ECHO to learn from ECHO. You may have I don't know what all you do, but you may have a specialized expertise. I know we have an attorney in the back there, and welcome. I think that you could, we have a legal ECHO starting to train rural attorneys to take care of foster children and give them legal advice. You could be an environmental engineer and start ECHOs around that. You could be an awfully rich man and contribute to ECHOs in different ways. You could connect us to people who have interested in starting ECHOs. There are so many ways, and especially, as I said, we are very interested right now in developing the world's best early childhood education program. We are going to harness the best practice from around the world, and we are interested in partners. But in terms of your specific interest, education is going to have more impact on the world, education ECHOs, than healthcare, as you heard from Dr. Kistin. So we are looking for partners, and do you want to address that?
Sure. So I have a card. I will talk to you afterwards about both parts of your question. But one thing to clarify is that if you want to partner with us as a hub, meaning you have an area of expertise that you want to get out to other spokes, then we want you to sign documents with us. They're very simple. They basically say that you will maintain the brand. We do not charge you for this. And it says that you will not take the myriad of materials that we're going to give you and sell them, and that you will share back with the community anything you develop in the course of doing ECHO. Pretty reasonable stuff. That contract has been signed by every academic medical center in the country, most governments around the world, and so really doesn't pose a problem. But to join ECHO as a spoke or an observer, you can do that tomorrow. You can get a list of the programs that are available for what you're interested in. In most of them, you can just go to the website and you can log on immediately to watch. Certainly that's true with the education network in Wyoming. Now, having said that, there are ECHOs that are not open to the public. Dr. Duhigg's sessions, for obvious reasons, are not open to the public. In Wyoming, the principals network and the superintendent's network is closed 3/4 of the sessions, but once a month they open the session to the public. So there are some restrictions. Most of the medical ECHOs are open to the public. So if you want to join as a spoke, that you just contact us or contact the website. That can be set up tomorrow.
I want to say something cool about this agreement, because it kind of sounds like, oh, agreement, what are you signing on to? The agreement says nothing is private that we present. Essentially, all of our education materials have to be shared freely. It's almost like an anti-intellectual property, this whole idea that if you sit on all your knowledge, nobody else benefits from it. So to be part of our cool ECHO Club, you have to share all of your knowledge, period, with anybody who wants it. So anybody in the world who started one of these clinics, they can just log on to this website that we created, and they can pull any lecture that any of us have given. They don't pay a cent for any of it. ECHO is free, and the whole idea is that if you increase access, then knowledge moves. It's awesome.
Yeah, and one thing I want to add to that is, in that comment is the idea of the physics of ECHO. Why does ECHO work? So if you had $10 and I said, can you share it with me? And you give me $5, you're poorer, aren't you? You're poorer by $5. But if you have knowledge and I ask you to share it with me, actually, you don't get poorer. In fact, the whole system doubles the knowledge, correct? And so knowledge operates on a different physics than money or gold or land or whatever else you want. And that's really why ECHO works and it flourishes. And that's why I just want to comment to the First Lady here. You know, I think that if the community people, and maybe you could comment on this, if our community comes together to make Albuquerque safe, nothing in the world can stop Albuquerque from becoming safe. Nothing in the world can stop it. And ECHO is just a tool, right? It will bring everybody together, harness their ideas. That's the sharing the knowledge. If people will share their knowledge of what they think their communities can become safer, and I don't know of anybody better than Elizabeth Keller to bring this community together, but did you have any comments about how you're thinking about achieving this?
No, I think one of the things I will say on the community partnership to model is to know that the knowledge piece, it's really important that the knowledge piece and for the participants is free. But it also takes resources to run these, right? It takes resources to make sure that spoke members who don't have a smartphone or who don't have an iPad or who don't have video teleconferencing equipment in their offices get that. It takes resources to make sure we've got partners from the university or partners from local companies that can do real evaluation to help us understand that we're really making a difference on those pieces. And on some of these pieces on the public safety, we have funded that with grants from a number of different places, from the Bureau of Justice Assistance, from state initiatives on opioid use. We're using a combination of funds coming through from Bloomberg Philanthropies right now to do the development and design of the Downtown Safety Echo. And we are working hard every day to continue to find where that funding is nationally that we bring in for this and some of those best practices. But we also think this is the kind of thing that Albuquerque would want to fund here, that we don't always have to go out to New York or go look to Chicago to fund those. And thinking through both through in-kind donations, right? Folks who are opening their conference room, which has great Wi-Fi and those pieces around for some of these get-togethers, but also of how we put dollars in together, both from public entities in terms of state and city funding out of operational budgets, but how we also open this up as we look to scale, not just about downtown safety, but about the city as a whole, and on these brighter initiatives, that it becomes a model too, that part of that collaboration and contribution can be through financial support of this model that it takes to have great people perpetuating this. So we're working on what some of those mechanisms will be. Stay tuned, but always welcome input from all of you on what you would like to see from that as well.
Please go ahead.
Yeah, I had a question, but I think the First Lady and you answered it. I think it's amazing the impact for Jeffersonism and for the medical field, but it blows me away having someone up to speed from this side of the world to that side of the world, and how children's literacy rates, it's incredible, especially in young girls across the world. So I'm wondering if you guys have like socioeconomic, because I know it's gonna get everyone up to speed, and just the literacy along the education. So I was just wondering, I don't know if it's just this fresh still at ECHO, but I'm wondering, and so I think you answered that. Thank you.
I think too, and you guys maybe add to the global pieces, but really that model about being able to better serve the underserved, to be able to leverage the technology resources, the case-based learning, all of that to make sure we've got that much broader, right? That kind of knowledge, those kind of services aren't just for a privileged few, whether that's safety, whether that's healthcare, whether that's education. So that is really, really core to the model. It takes continuing to develop and design those with those pieces in mind, but I think pretty core to how these are being developed and rolled out and replicated reflects that as well.
I think we have time for one more question before they're going to turn out the lights. So is there any more? Are there any?
There's one in the back there. On the back on the left. Yeah.
Hey, thank you. This is more geared towards Dr. Duhigg. So I know that you work in psychiatry, but you also work in addiction, as do I. So my question is, and it's been in the news recently that telemedicine can now be applied towards opioid abuse. How do you see that being applied? And if ECHO does intend on making a push towards substance abuse?
So it's a great question.
Yeah.
And actually, so there have been substance abuse or addiction or substance use disorder focused echoes almost from the start.
Awesome.
The original one was the integrated addictions and psychiatry that was focused on mental health in general, including substance use disorders. There are now a number of those across the country and in other countries. What we also see happening is pairing our chronic pain management echoes. They end up handling a lot of content focused on opioids and opioid use and also other substance use disorders. And there have also been a network of echoes specifically focused on the opioid epidemic. And so there's actually quite a rich legacy at this point, really, of investing in trying to address the problems related to substance use disorders, and the ECHO model has been awesome for that. A lot of the work that I do these days is trying to get other healthcare providers, physicians, and nurse practitioners to treat addictions, treat substance use disorders. And it might be surprising to most of you, but in medical schools, this is not really taught. Right? This explains a lot. And so what folks find is that when they have access to an addiction psychiatrist once a week that they can ask questions to, and I can give them advice on their cases, they are far more likely to try the treatment. And that's exactly what we see happening. So it's really been quite amazing.
I want to just add that in 2016, we published a paper which got the award for the best paper of the year in Substance Abuse Journal. And it was based on the idea that when we started that opioid addiction echo here, 2006, there were only 33 doctors in this state who had the ability to prescribe Suboxone, which you're obviously familiar with. We trained another 500 and certified them. We published this. This got the award for the best paper of the year. And then, now 40 states in the United States are using ECHO for opioid addiction. And the last thing I want to mention, 3 weeks ago, the Opioid Response Act was passed, as you know. It's now the law of the land. It's been signed by President Trump. It specifically says that the federal government has to give grants to people who use ECHO for opioid addiction. So this is a very big focus area for us.
I'd like to get some of those business cards you were talking about.
Yes. I think the last piece to note is just how the echoes cascade from each other. So I think the gentleman in the back who asked the question about getting together face to face may have been a question of just, do those Hollywood squares ever meet in person? And then what Dan noted also, though, is this meta echo, which is the chance for each of those sets of Hollywood squares to be learning from each other. And so, for example, where we are now in the city and thinking about developing this echo for downtown safety professionals. So this includes folks beyond the sort of sworn officer community that Dan works with, to include folks from other city departments, the transit security folks at the parking lot attendants, folks in Parks and Rec, right, who are dealing with opioid addiction pieces on a regular basis, to work across those city departments, to work with other entities, to work with private sector security and the other interfaces. But through the ECHO network, we have the chance then to pull on not just what is the best addiction specialty training we provide in APD, and the folks Dan works with, right, have very specialty training to get that out, but also to be able to look across all of these ECHO communities working on the pieces of addiction and be able to pull that in also to the knowledge base and quickly kind of demonopolize that, not just to sworn officers, but to a much broader community that is now confronted with these issues on a regular basis. So that learning within these tiny networks and across them, I think, is really vital. And as you see these build out, how powerful that is to be able to pull those issues that all intersect.